A 49-year-old woman presents with a 7-year history of chronic frontal migraines with right retro-orbital pain and no changes to her vision. Previous interventions have included trigger point injections, occipital stimulators, Botox injections, as well as prescription medications without relief. A CT scan did not reveal any craniofacial abnormalities that would explain her symptoms. She has also undergone bilateral supraorbital and supratrochlear nerve releases with fat grafting about 4 years prior to presentation with no successful results. So this is a 49-year-old woman with chronic bilateral frontal migraines, and she has had failed attempts at non-operative management as well as failed supraorbital and supratrochlear nerve releases with fat grafting. How would you face the case? Option A, bilateral supraorbital and supratrochlear neurectomy using an avulsion technique. Option B, transection of the supraorbital and supratrochlear nerves bilaterally and regenerative peripheral nerve interfaces, or RPNI.
The votes are in, and you chose B.
Hi everyone, I'm excited to discuss this interesting case of a patient who underwent unsuccessful nerve decompression of the supraorbital and supratrochlear nerves, and then successful nerve transection and nerve end reconstruction with RPNI. I would say in my own practice, I'm very cautious about offering neurectomies because I know there will be permanent numbness and there's always a risk of neuroma formation and chronic neuropathic pain. So personally, I would start by doing serial nerve blocks to try and identify whether it might only be one nerve or both nerves, maybe only one side or both sides that are causing the patient pain. And I would offer very selective neurectomies if needed. I'm glad to hear that the authors picked RPNI for nerve end reconstruction. Personally, especially in this area, I am not a fan of traction neurectomy because when you do that, the nerve retracts back into the orbit and the orbital fat, and it is very challenging to find the nerve end again should there be another neuroma that forms and should we need to do a nerve end reconstruction. In terms of what technique to use, I think RPNI is a good technique to reconstruct the nerve end. You can of course use TMR as well. It's unclear at this point in headache surgery or for head and neck nerves what the best technique is, so this is a good example of that RPNI can work. The authors used the brachioradialis muscle as their donor, and I think I would also consider using a muscle close by, such as the glabellar muscle group. I don't routinely remove the corrugator muscle during decompression, so it would still be there if I had done the decompression, but maybe that was not the case in this scenario. So anyway, congratulations to a good outcome, and thank you for another interesting contribution to the literature.